Good morning, everyone. Can you hear me?
Yes, we can.
Hi, Dr. Tawa. Hi, everyone. So it's 5 p.m. here in Africa, 2 p.m. in Europe. So I will moderate today's meeting in behalf of Jack, and the moderator will be Mohamed Bekait, and the panel members will be Safan Tower and Raman Gol. So welcome, everybody. We will have 3 presentations and 1 keynote lecture by Professor Sadeja Pintar. So I will start with the first presentation. The presenter is Rudrik Takar, and the presentation will be a closed loop audit of hepatocellular carcinoma surveillance at an upper GI surgical unit. I'm sorry that I don't have the webcam with me, but my connection here in Africa is a bit slower, so I prefer to not open it. So Dr. Rudrik Takar, please, can you start your presentation and can you...
Can you hear me?
Yeah, we can hear you. We can hear you. Please, you can share your screen and thank you.
See my screen now?
Yeah, we can. Thank you.
Thank you very much for the opportunity this afternoon. My name is Rudrik Tucker. I'm a surgical clinical teaching fellow, currently based at Somerset Hospital in Taunton. I carried out this audit while I was a foundation doctor in Salisbury. This is in Wessex, in UK. This is a closed loop audit of hepatocellular carcinoma surveillance at the upper GI unit at the hospital. Starting off with the background of liver cancer. These are the statistics from the Cancer Research UK. It shows that annually there's around 6,000 cases in the UK, and yes, 5,000 deaths. This is 2016-2018 data though, and the survival rate, the prognosis isn't very good. It's 13% only in England, and the prevention, approximately 1 in 2 patients will be prevented from the liver cancer. So I think it's a very important disease in the UK, around the world as well. And a little bit more about the HCC itself. It's commonly in patients with cirrhosis, hence I focus this audit in the patients who are coming to hospital with cirrhosis and their follow-up. And we know the HCC is the most common, 90% of the liver cancer, and in particular causes 4,000 deaths in the UK on its own. And looking at the British Liver Trust, they say that it's the 9th most common cause of cancer deaths in the country. And since 1990s, it's almost doubled. So yes, it's increasing, as we say. And the mortality, as you can see, is also the largest increase in the last 10 years compared to all the cancers. And the concern being is asymptomatic at the start, hence it's quite difficult to identify and pick, although it's quite important when we do find them, we surveillance them, and hence that's why I focus on the follow-up patients, hence they get the adequate treatment on discharge from the hospital. So we use the NICE and the local hospital trust guidelines, which recommend that patients with cirrhosis should have a 6-monthly follow-up with ultrasound scan of the liver and also a blood test looking at the alpha fetoprotein. And that's why I focused my audit on. So the method, I did 2 cycles. I did a cycle end of 2018 to April 2019. These are patients coming to hospital at Salisbury with cirrhosis, and I followed them up in 6 months' time and checked how many of them actually had the follow-up. And I presented data at the hospital, the departmental meeting. We put up posters for the discharging team, because I think as foundation doctors, we were not aware of this. So we would recommend the discharging team to actually book the follow-up, by themselves, rather than wait for anybody else to organize a follow-up. So we would be booking the scan and the blood test for the patient. And then I repeated the cycle following the intervention in the end of December 2019 until May 2020. So there were 2 cycles. And as I mentioned, collected data on the scan, ultrasound, and the AFP blood test. Exclusion criteria were patients who were less than 18 and patients who were already known to have metastases and were not reactive, hence palliative management. So this was the audit method. Okay, the result of the first cycle, we had 55 patients and the second cycle was 42 patients. So again, this is the second cycle is just the start of pandemic, so this could be the impact of patients coming to hospital, less patients coming to hospital with cirrhosis, possibly. The gender, we had 49% were male, 51% were female overall. And the age, average mean age in first cycle 65 and second cycle 61, roughly was 63 average age overall of the patients. And this is just the summary of the 6-monthly follow-up. In the first cycle, 31 roughly % of patients had follow-up ultrasound scan on following discharge, this is, whereas in the second cycle, again, this is the pandemic, so I think the COVID-19 could have impacted the follow-up and the results here we're getting. So it was 33.8, small increase, although yes, it showed we did manage to maintain the service with the intervention. And the AFB blood test here, again, in the first cycle got 34.5% patients having 6-monthly follow-up. This is slightly improved to 43.8% in the second cycle. And this audit demonstrated the intervention that we did, which was to discuss with the discharging team to organize the follow-up, and also posters and the meeting presentation has showed slight improvement of the follow-up in the surveillance for HCC. Although, as I was saying, the COVID-19 did impact, I think, the follow-up service we had in 2020. So I think a repeat audit we want to do soon would be good to understand the current practice and see how we're doing now, really, after the COVID-19 pandemic. So it was a really short audit, but if you've got any questions, I'm happy to answer. Thank you for your time.
Has to our panel members if they want to discuss this presentation. Thank you. Please,
no, not really. Actually, I mean, it was very well presented. I like the way you sample the data and how you choose it. But there are limitations for any data collection, but I don't know. I like the way you did it. I have really no specific shortcomings about it. Thank you very much for the presentation.
Thank you very much.
Thank you, Rudit, for your presentation. I think the data was the only issue I have is I would have loved to see what was the follow-up before COVID times. What was the kind of follow-ups that were maintained in the same hospital with the similar guidelines, because that would show how the things have changed during COVID. What you are going to do now as prospective data collection in post-COVID, if you had put that would have shown how that's the only thing that matters, because most of the surveillance related issues are known with hepatocellular carcinoma, and we know there are various limitations, but the impact of COVID is for what this data brings forward. So thank you once again.
Just to highlight, pre-COVID, the first cycle actually was end of 2018, 2019. So the 6-monthly follow would be end of 2019. So the pre-COVID data, as we got here, is 30.9% in 6 months ultrasound follow-up. And the AFP was 34.5. So this is just pre-COVID. This is end of 2019. So yes, that's just wanted to highlight. The first cycle was pre-COVID, yes.
So you wish to say that this has improved, the follow-ups have improved in post-COVID period?
No, I think the second cycle was towards the end of 2020, sorry. So I think we haven't improved, we've improved slightly, but not a lot. And we think it could be because of the disruption because of COVID for the follow-up. So I think the plan is to redo it now and see how we're doing. So this would be pre-COVID, and then post-COVID.
Okay, thank you.
Thank you very much.
Thank you so much. You can go ahead with your second presentation, and then we will give the space to Dr. Sorobi Chatterjee. Okay.
Sure. I can.
Thank you so much.
I'll just stop sharing this screen and I'll reshare the next one. Can you see my next presentation?
Yes, thank you. Thank you.
Thank you so much for your time again. for the second presentation, which is the work I've done at the current job as a surgical teaching fellow at Somerset Hospital. This is looking at the appendicitis and the investigation management and the negative appendicitis rate in particular. This is pre-COVID, COVID, and post-COVID as well. Sorry, can you hear me?
Yes, now we can hear you.
Now we can hear you back, yes. But we lost you for a minute.
Apologies. I'll share my screen again. So this is yes. Could I check when was last you heard me? What slide was it? The aims?
We lost you right from the beginning.
Oh, thanks. Sorry, I'll restart. Thank you. Can you see my screen?
Yeah.
Okay. So this is a second audit which I've done at my current hospital at Somerset in UK. This is looking at management of appendicitis pre-COVID, COVID, and post-COVID, and the management, and in particular the negative appendicitis. This is because during COVID we were recommended not to operate because risk to the patient and the staff. And the COVID harem audit in the UK found that there was increase in conservative management and decrease in negative appendicectomy rate. So this was the main focus. To look at the year down the line, how we've recovered and the current practice in our hospital. So data was collected of patients who presented to the surgical assessment unit with appendicitis or clinical suspicion of appendicitis requiring diagnostic laparoscopy. So 3 months we focused were from 23rd of March to 23rd of June. This is 2019, 2020, and 21, 3 years. We looked at the electronic records and the exclusion criteria were patients less than 18 years old. The results, number of patients in the first cycle, this is 2019, was 59 COVID, 46 in the second because of COVID, there was reduced admission rate. 2020 this is, and then increased significantly in 2021, which was 69 patients in that 3-month period. The mean age was 42, and there were 45% of male and 55 of female. So the mean length of hospital stay was 3.3 days. 2019, 3.9, slightly increased possibly because of conservative management in 2020, and 3.5 again in 2021. So looking at the imaging they've had on admission, we found that again, because of the pandemic, there were less ultrasound, but more CT scan. As you can see, the 2020 results show that significant increase in CT scan for diagnostic purpose. Again, in 2021, it's slightly gone back to pre-COVID now. So only 46% of patients having CT in 2021, that were 37% in 2019. And same with ultrasound is pretty much the same as pre-COVID time, 41 in 2021 versus 36% in 2019. So yes, more CTs during COVID pandemic. As just mentioned, the conservative management at our trust was almost 1 in 2 patients had conservative in 2020. But again, in 2021, a year down, we've got 19% having conservative management compared to 5% pre-COVID. So yes, the main the findings for negative appendicectomy rate, which was none during COVID-19 pandemic, because we had CT evidence of patients having appendicitis. Although in 2021, year down is 5%, and pre-COVID was 12%. So it's definitely significantly reduced negative appendicectomy rate post-COVID, which shows improvement in service possibly. And the conclusion from this study was that there's change of practice during and following the pandemic. As we know, the more patients are having diagnostic imaging, CT scans, and even now so. And there's improvement of the negative appendicectomy rate, which shows a good in our service at the hospital. Although the changes have reduced, though, they've almost pretty much are as pre-COVID now. And yes, we're seeing this improvement in the negative appendicectomy rate. This could be because of more patients having CT scan. So again, a small but really useful to understand what we were doing during COVID and now 1 year down the line after COVID at the hospital at Somerset in UK. Thank you. Any questions?
Yeah, actually, I have a comment rather than a question. I mean, I don't know, but most of the surgeons I know don't agree with the term negative appendicectomy, just like we don't agree about the negative laparotomy. So when you do a hemoglobin and hemoglobin is 9.5, that's not a negative hemoglobin. That's a low. That's low hemoglobin. Exploratory laparotomy is an investigation, and when you're not sure about the appendicitis, what we do for our residents, we don't know. I mean, when you go for a patient and it's a query appendicitis, we don't write for appendicectomy. We write for laparoscopic exploration. And if it turns out to be not an appendix, then that's not a negative appendicectomy, a negative whatever, or positive appendix. I mean, a negative biopsy, no appendicitis. That's not a negative appendicectomy. The thing is, having 5% appendicectomy rate is a bit dangerous, because I mean, if you have more than 90% accuracy in pathological proof of appendicitis, that means you are missing the early cases, and those cases will present later with perforation. If you go into the studies that study perforated appendicitis, the vast majority, more than 66%, have been to an ER generally twice, sometimes once, sometimes three times, but generally twice, and they were discharged because they thought they had nothing, which was an early catarrh or whatever appendicitis. So I don't see 5% in and as an improvement of normal appendices, if you like, as an improvement. I think it's a negative thing. We should maintain 10 to 12% more or less normal appendices histopathologically to be on the safe side and not be missing early appendicitis. Thank you. My 2 cents.
Yeah, thanks. Roderick, a good study, but it's a unique opportunity to see that all these patients, I mean, they were not part of this study for you. All these patients who did not have who all went on conservative management, how many of them ended up with complications related to appendicitis? I think that would be a very interesting, because this kind of event will never happen again in our lifetime, where most of the patients are managed conservatively. And another take-home message is that if CT is able to avoid negative appendicectomies and related complications, do we need to move on to more CT-guided diagnosis of acute appendicitis? So I think, as far as your study is concerned, a good one, but I think it opens up a Pandora of research topics that can, analyzing the data to find out specifically for acute appendicitis. Thank you for the presentation.
Thank you so much, Dr. Takar. Thank you for the discussion. We have some question on the chat for Roderick from Dr. Body. What percentage of patients had some sort of imaging before surgery?
What percent had imaging before surgery? Sorry. This is the slide, I think, probably answers the question. The imaging, these are the imaging for all patients who had the surgery. This is pre-COVID and post-COVID. So CT, as you can see, is 63% in 2020, and 21 was 46%. So does it answer your question?
Dr. Body, can you?
Yeah, no, I was after, some of these patients will have had both a CT and an ultrasound scan, and some of them will have had neither. So what proportion had some sort of imaging before their surgery?
Sure. So this is all the patients in our study. So as we were saying, these are the number of patients this is every single patient in that data collection we had, and it shows, so yes, it shows the scans they've had. So yeah, this doesn't exclude anyone. Sorry, if that answers the question.
No, because some of those patients will have had just a CT, some of them will have had just an ultrasound, some of them will have had both, and some of them will have had neither.
Sure. So sorry, I think the way I've presented the data is 2020, 69 of that 41% had ultrasound and 46% had CT. So I've included all of them, and they are separate data here, if it helps. So I've kept it really simple. 69 of patients in 2021. Of all of them, only 41 has ultrasound and 46 had a CT. I haven't looked at I haven't presented it the way that it shows both of them had both, or none of them had none. If that answers, I can do going forward.
Okay, thanks.
Thank you.
Tucker for the presentation. Now I can gently invite Dr. Surabhi Chatterjee for a presentation. She will speak about the use of machine learning in different fields. Are you here, Dr. Chatterjee? Can you share your screen, please?
Hello, am I audible? Hello.
Yeah, we can hear you. Can you share your screen, please?
Oh.
Can't hear her. See the screen.
No.
Can you hear? No, we cannot see your screen.
Hello, is the screen visible now?
No.
Not yet.
Wait a second. দাদা এখন আসিস না।
Sorry, we cannot see your screen. Did you already has the ability to do that?
Yeah, I think I can see my presentation. I don't know why it's not being shown.
Maybe you can send it to me and I can share it.
Oh, okay.
Meanwhile, if Dr. Pinter wants to start a keynote lecture, and then we can go back to.
Yes, we can start. I will prepare.
Thank
I will share the screen.
Thank you.
Can we see each other? And here?
Yes.
Okay. So hello everybody, it's my privilege and honor to today present the next presentation targeted to COVID-19 and bariatric surgery with new insights. This is just a short literature review, what was happening about at the time of COVID-19 and what are our perspectives for the next future. So the coronavirus disease pandemic is making havoc on society, especially in healthcare systems, including disrupting bariatric and metabolic surgery. The current limitations on accessibility to non-urgent care undermine post-operative monitoring of patients who have undergone such operations. Most likely elective surgery, new bariatric and metabolic procedures have been postponed worldwide during the pandemic, and when the outbreak abates, a backlog of people seeking these operations will exist, and the number of is increasing worldwide. Hence, the surgical candidates face prolonged delays of beneficial treatment because of the progressive nature of the disease. Obesity and diabetes. Delaying surgery increases the risk of for morbidity and mortality. New strategies are then needed to mitigate the harm. The risk of harm, however, varies among the patients depending on the type and severity of their comorbidities. Robinson presented in the study that was published in Journal of Appetite that lockdown disproportionately have a large.
Could I interrupt you? We are not seeing your further slides. We are seeing the first slide only.
Oh, then I need to. I will. Is now better?
Yeah, this is
okay. Now it's going.
Yes. So I will go from full screen to the smaller, so it will go on. So in the study of Robinson et al. Published in Appetite. Clearly presented that COVID-19 crisis had a disproportionately large and negative influence on weight-related behavior among adults with higher BMI. At the same time, in August 29, Brooks et al. Published in eClinical Medicine effects related to pediatric BMI changes during the epidemic and concluded that children's rate of unhealthy weight gain increased notably during COVID-19 pandemic across demographic groups and most prominently in children already vulnerable to unhealthy weight gain. These data can inform policy decisions critical to child development and health as the pandemic continues to unfold. Also, it is clearly presented that the increase in the rate of BMI change was highest among the groups of children who are already most vulnerable to unhealthy weight gain, and these studies support careful consideration of the physical, social, educational, and mental well-being of children as the pandemic continues, with a special attention to the role of decreased physical activity and increased electronic use may play in the future. Besides that, it was clearly presented with Zachary et al. That the future perspectives of increasing weight gain, also waist circumference, BMI in the UK are alarming. Calculated up to the year of 2035, with the same increasing of all trajectories of childhood obesity into the adulthood, presented in the New England Journal of Medicine in 2017. The study based on simulation models childhood obesity and overweight will continue to be the major healthcare problem. Presenting categories are age, BMI, and obesity status. We can speculate that postponing the mandatory interventions, including bariatric surgery, will have even more negative impact on the growth of observed variables, health, and related costs. Taking in mind the up-mentioned facts, our triaging strategy is therefore need to prevent, reduce, and postpone morbid obesity complications short and long term. Speaking about the risk of disease progression from delayed operation regarding to class 2 to 3 obesity, joined with type 2 diabetes, prognostic factors of morbidity and mortality in obesity and type 2 diabetes, calculated complications powerfully reduce quality of life and exacerbate obesity-associated mortality. Even before COVID-19, obesity reduced life expectancy was calculated to be 5 to 20 years. Also presented in different studies, DRM2, ABCD, and others that clearly presented the benefits of bariatric surgery to type 2 diabetes treatment. Regarding to obstructive sleep apnea, mortality from untreated obesity hypoventilation syndrome can be as high as 24% at 1.5 to 2 years after diagnosis. Obesity is clearly related to heart failure, is associated with increased mortality, and for each unit of increase of BMI unit, heart failure related mortality increases by 1.4 times. Regarding to metabolic fatty liver disease, that is presented in 66% of morbidly obese patients, leading to cirrhosis in 15 to 20% of cases. Metabolic surgery results liver disease in 8% of patients. But it is mandatory to add the data that the risk of hepatocellular carcinoma is related to progression of MAFAD, and this should be also calculated to the all-over risk of morbid obesity and joint complications. About the cancer risk, bariatric surgery is associated with a reduced risk of all types of cancer, with a significant odds ratio of 0.72, with confidence interval about 0.59 to 0.87, and obesity-associated cancer with a statistically important confidence interval and odds ratio. What is about the postponed bariatric and metabolic surgery interventions regarding to the cost, survival years, total quality of life years, incremental costs, and the incremental quality of life, that it was analyzed by Galvin et al. And published in SOART in 2020. The study based on Markov model and compared lifetime costs and outcomes of bariatric and metabolic surgery regarding to conventional treatment among patients with body mass index over 40, then over 35 with obesity-related comorbidities, or BMI 35 with type 2 diabetes in the second group. Model outputs included costs and quality adjusted life of years with a scenario that analyzes whereby patients experience COVID-19 infections. Bariatric and metabolic surgery was delayed by 5 years, and bariatric and metabolic surgery patients underwent endoscopy only. The paper clearly concluded that when COVID-19 infection was considered, bariatric and metabolic surgery remained dominant. It prevented death, hospitalization, and intensive care unit admission in comparison to non-operate morbidly obese cohort of patients. Importantly, delaying bariatric and metabolic surgery for 5 years resulted in higher costs and lower quality of life years in both groups compared with non-delayed treatment. Compared with the base case, net monetary benefit remained positive and was decreasing in a group A and in a group B. Bariatric and metabolic surgery was dominant versus conventional treatment in both groups. Delayed surgery compared with the base case net monetary benefit remained positive. and the bariatric and metabolic surgery was dominant versus conventional treatment in both groups. The Baranquero published in obesity surgery in 2021 the importance of follow-up after bariatric surgery at the time of epidemic, and presented clearly that at the time there was a significant reduction in all patients' comorbidities in 1 year after bariatric surgery, but the net drop of BMI was lower when patients were not followed in phase compared to electronic follow-up. This also presenting the vulnerability of the patients included in the study, or the need of in-phase follow-up in this cohort of patients. About follow-ups, there at all published in Obesity in 2021 and presented that a significant difference in weight loss between the in-person and telemedicine groups, suggesting that weight changes among the later group may not be accurately reported. Then the utility of weight loss data obtained from bariatric surgery patients during the pandemic should be discussed, and the significant deviation from the in-person groups suggests inaccurate reporting, whether intentional or unintentional. De novo presents the vulnerability of the patients undergoing bariatric surgery and vulnerability the morbidly obese patients in general. Emnian et al. Presented the study in the study published the importance of bariatric and metabolic surgery. The cohort of study was operated with Roux-en-Y bypass between 2004 and 2017, and presented that substantial weight loss after bariatric surgery was associated with the improved COVID-19 outcomes compared with non-surgical contrast, including 49% lower risk for hospitalization and 60% lower risk for developing severe disease. Data also show that in this cohort of patients, the hazard ratio for COVID-19 hospitalization was lowered for 0.1, the need for supplemental oxygen for 0.37, and for severe COVID-19 infection for 0.4. That is highly important result, with the conclusion obesity is a modifier risk factor for COVID-19. What about the prioritization and in resuming elective bariatric and metabolic surgery procedures? It was discussed and clearly presented with the paper of Rubino et al. Published in Lancet Diabetes Endocrinology in 2020. Clearly put out the prioritization of any elective operation should seek to facilitate access according to clinical need, maximize quality of access, and minimize the harm from delayed access. The risk would be indicated for a poor glycemic control despite maximal medical therapy, use of insulin, previous cardiovascular disease, albuminuria, chronic kidney disease, non-alcoholic fatty liver disease, and multiple cardiometabolic comorbidities. Besides, insulin use is a meaningful prioritization criterion because it correlates with the increased cardiovascular mortality and reduced quality of life. Bariatric surgery in epidemic, the study of The prioritization in resuming elective in bariatric and metabolic procedures have been clearly proven by Rubino et al. In the same paper with the categories presented in the slide. And that are clear and need to be incorporated into the daily clinical practice, even in the at the end of COVID pandemic, to reduce the harm of the postponed surgical interventions. What about the bariatric surgery during pandemic? It was clearly presented by Singhal et al., published in Obesity Surgery, where and the authors analyzed the 30-day morbidity and mortality of bariatric surgery cases during COVID-19 pandemic. And the authors concluded that bariatric surgery during COVID-19 pandemic is safe, and that the postoperative risk of infection was only related to the peak of infection in the local circumstances, and there was no other special risk factors related to bariatric surgeries during the COVID-19 pandemic. In conclusions, the coronavirus disease pandemic is wreaking havoc on society, especially on healthcare systems, including disrupting bariatric and metabolic surgeries. The slide clearly presents the relation of obesity and comorbidity diseases to the harm of COVID-19 outcomes in different countries, with the different incidence of morbid obesity or obesity trends and obesity-related diseases, and of course the harm of COVID-19 disease and the long-term consequences. Lockdown has had disproportionately large and negative influence on weight-related behaviors among adult children and adolescents with a higher BMI. The risk of disease progression from delayed operations is increased due to the long-term risk of all-cause mortality compared with matched non-surgical patients. Delayed obesity surgery increases the all-over risk of cancer and cancer progression. This is another hot topic of bariatric and metabolic surgery that have to be solved in the next future. Post and bariatric surgery, when COVID-19 infections were considered, bariatric and metabolic surgery remains dominant. It prevented the death, hospitalizations, and intensive care unit admissions. Delaying bariatric and metabolic surgeries by 5 years resulted in higher costs and lower quality of years' life in both groups compared with non-delaying treatment. Also, coming from the conclusions with the same paper, bariatric surgery candidates will have more associated diseases and higher over risk in the future. Bariatric surgery reduced risk for hospitalization, need for supplementary oxygen treatment, and severe COVID-19 disease. Another benefit of important benefit of bariatric and metabolic surgery. Priorities in resuming elective bariatric and metabolic surgeries are needed to be implemented in daily practice now on. Bariatric surgery during the COVID-19 pandemics is assumed with appropriate perioperative protocols. Due to the high vulnerability of patients, it is necessary to implement interventions that ensure safe and effective treatment. Thank you very much for your attention, and if any questions, I will be glad to answer.
Thank you so much, Dr. Pinto, for your...
Sorry, please go on.
No, as well, thank you a lot, Dr. Pinter. Please go ahead, Dr. Tawa.
Yeah, I mean, I just want to congratulate you for collecting those data. It's a wonderful presentation, being a bariatric surgeon myself. So I really enjoyed every slide and every discussion. Thanks a lot. And you are absolutely right. I mean you showed the data, delaying bariatric procedures, elective ones, are not only very costly, but it's detrimental to the patient's health with everything that you outlined. And just like point 10, we at TUGS, we published very large data with international surgeons who worked during the pandemic, and including our hospital. We never stopped. We were doing elective bariatric procedures during the height of the pandemic with very stringent perioperative protocols. And believe it or not, we didn't have a single case of COVID infection to the patients or to the staff. So I have nothing really to criticize. It's a wonderful presentation. Thanks. It's a pleasure listening to it. Thank you. I wonder if you can share it with us. Of course, we refer to when we share it to our doctors, but this is very much enlightening. People will need to really know about that. Thanks a lot for the effort.
Yes.
Thanks a lot for presentation.
I can just say that I choose some topics to discuss that are much more alarming for the bariatric future or the future of all bariatric surgeons, but there are many of them remaining to discuss, and that will probably have a big power in the future, because regarding to concomitant diseases that are growing in the incidence, and we will really have to do our mission with let's say much more diseased patients in the future. This will also increase the risk of bariatric surgery in all, and need to be put much more attention to pre-operative preparation, and also the follow-up instruments that should be intensified in the future, I suppose.
Thank you very much. I'd love to have a copy of this presentation, really.
Okay, I can send you by mail if you want to.
Please do. You have my email. Thank you very much.
Thank you.
Appreciate it. Quite interesting.
Right,
Thank you.
Professor Tareja. Thank you for such a wonderful compilation. You know, we have come a long way from the initial publication of 20% mortality that came from China initially, and that scared all bariatric surgeons worldwide. But I think now the data has spoken, it's very, very evident. And I think one of the things that we need to look at it is we are seeing a very large number of revisional surgery patients who are getting delayed for last 2 years, people who have been waiting for reflux disease or weight regain. And suddenly we are seeing a very high percentage of revisional patients coming once the COVID is going down. So I think that's also one of the areas that we will have to look at it, that how the revisional surgeries got delayed. So thank you very much once again for the presentation.
Can I ask you, maybe speculate this is also related to the different lifestyles during COVID-19 pandemics, because there was significant BMI increase also in the operative groups, and of course the reduction of attention to the lifestyle recommendations is one of the topics of the redo bariatric surgeries.
Yeah, sure. Thank you.
Thank you so much. I will proceed with Dr. Chatterjee. I'm going to share my screen with her presentation. And are you here, Dr. Chatterjee?
Yes, I am. Am I audible?
Yeah. Dr. Pinter, can you stop your screen, please? Okay, thank you. Okay. Oh, wait. Wait a moment. All right. Okay. Okay. Okay, you can start speaking, and I will just move on with your presentation.
Okay. So, greetings to one and all. I'm Sarobi Chatterjee, and I'll be presenting the topic diagnostic performance of machine learning algorithms versus conventional MRI for brain tumors. It's a systematic review and meta-analysis that we recently did. So, next slide. So we'll be covering our topic. First, we'll discuss about what is machine learning and artificial intelligence and how does the two compare. What was the objective of doing the systematic review and what was the problem statement? Next slide. The methodology, the results, the conclusion, and finally, we'll also discuss about artificial intelligence and upper GI tumors. Next slide. So let us first look at the timeline of artificial intelligence and the slow development between artificial intelligence, machine learning, and then deep learning. So in the 1950s, the first programs that were used to model computers to the modeling system of human brains were first started back in 1950s with the development of artificial intelligence, wherein intelligent machine and program systems were first being engineered. Gradually, in the 1980s and 1990s, machine learning was being developed, which could actually understand and slowly even start predicting the systems based upon whatever input was being provided without explicitly being programmed. There were some unsupervised learning systems as well as some supervised learning systems that were being developed during this era. And finally, in the 2012s and now, we have the deep learning system, which works similar to the neurons in our brain, like synapses, wherein the different layers of networking system works together and helps us to give a particular data set as an output. Next. So the biggest confusion lies between artificial intelligence versus machine learning versus deep learning. So in simple terms, we can say that each one is a subset of the another. Artificial intelligence is the main globe, out of which machine learning is a subset of it, which includes all those statistical methods to help us improve with the given set of data. And as robust as your input system, the more robust will be your output. In deep learning system, it's a subset of machine learning, which also uses this input which is provided, but it uses its own intelligence on the basis of its prior experience. And then at the end, it gives us the final output or the final result, which may be diagnosis or prognosis. And the main point is it uses multi-layer neural networking. Next. So the most important kinds of network that we use, as I've already discussed, are machine learning, deep learning, and neural networking. Next. So the key differences between machine learning and deep learning in simple terms could be explained with the help of a small diagram. Like if we give input in the form of a cat to a person, then if we give this to the person, then we will know if the answer is cat or not. While if we are giving the input in the form of deep learning as cat to the next person, then using prior experience, it will also not only realize whether the answer is a cat or not a cat, it will also help us realizing what breed of cat it is based upon its prior experiences of all the different kinds of data of the cats that it has received. So the key differences between machine learning and deep learning is, for machine learning, you require a relatively smaller amount of data as compared to deep learning. It is quicker to train a model as compared to deep learning. And the accuracy, however, plateaus with the help of data analysis because it's as good as the input which is being provided. Deep learning learns from the experiences, learns from all the mistakes that it has done, much like a human brain. And thus, it is conceived that it has better accuracy. The amount of data that is required for deep learning is also more, so it trains better on a GPU, whereas a machine learning can easily function on a CPU. Next. overall, in a very small gist, we can say that there are three basic kinds of machine learning that are being used in medical science today. There are also several other types. So there's supervised learning, unsupervised learning, and reinforcement learning. The one that we'll be discussing and most of the diagnostic performances based on is on the supervised learning classification system, which uses decision trees, support vector machines, and random forest models in order to predict whether the given training system to diagnose whether it is precancerous or not. Next. So out of the top machine learning.
Sorry, Dr. Sadaj, we have only a few minutes because we have
Okay.
like in 30 minutes will be another meeting. So please let me.
Okay, so could you skip the slide? The next one also. Yeah, we can start with the problem statement. Yeah. So as we know that brain and CNS cancers involve a whole incidence percent of 1.6, and 4 out of every 100,000 people in the world are diagnosed and 3 out of them die. Can we move to the objective slide? Slide 14. Okay, so our primary objective is to assess the diagnostic accuracy of machine learning and compare it with conventional magnetic resonance imaging. Next. So we included all the original studies and compared their data, and we reported the sensitivity, specificity, and number of patients and created contingency tables for it. Next. We excluded all non-human studies and studies for which we could not construct a diagnostic contingency table. Next. So this is how we progressed. Our strategy included all the databases that we could find: PubMed, Scopus, Google Scholar, and Cochrane, and all the studies from 1980 to 2021 was included. We used QuadAS2 for risk of bias assessment, and the data collection was done by 4 authors, and finally 2 authors evaluated the final result. Next. So overall, 12 studies were included in the final systematic review, and 10 studies out of all the given studies were included in the meta-analysis. Next. So the findings of our study is on comparing conventional MRI to machine learning was that the best sensitivity and specificity reported by magnetic resonance spectroscopy by Goda and Zhao et al. At 100% each. The highest negative predictive value was also 100% using dynamic susceptibility contrast MRI. And amongst all the advanced MRI, perfusion weighted imaging was the least accurate. Next. On compared to machine learning algorithms, it also had similar sensitivity and specificity, and random forest model outperformed all the other models. But the best AUC was provided by deep neural networks. Next. Next. So finally, the machine learning algorithms had a pooled sensitivity and specificity, which was better as compared to conventional MRI. The diagnostic odds ratio of conventional MRI was also better at 1191.33 as compared to machine learning algorithms. We skip here deep learning and esophageal precancerous lesions. So now I'll also discuss about one of the most recent systematic review which was done on comparing deep learning and esophageal precancerous lesions. Basically, next slide. Yan et al. Did a study in order to understand whether esophageal precancerous lesions that were first understood as could be compared, and whether we could differentiate between the different forms of low-grade and high-grade intraepithelial neoplasms. So first of all, the input in the form of after doing an endoscopy was given, and then using handcrafted feature extraction, machine learning was used. For deep learning, they used both convolutional neural network as well as deep learning system to predict whether the given system was intraepithelial neoplasia or was a normal finding. Next. Can we zoom it in? The previous slide. So there were total of these 10 studies that were included from 2017 to 2020. Out of these, the maximum sensitivity was of SegNet, which was at 96.1%, and the maximum specificity was by ResNet at 98%. The best accuracy was of LNet. So a total of 10,000 patients. Overall, these 10 studies were included, but most of them were retrospective studies. And they used deep learning and convolutional neural networks, which outperformed even the traditional machine learning systems. The total diagnostic odds ratio using these were 1242.2 as compared to using traditional machine learning, which was 941.2. Next. So the final roadmaps for machine learning and tumors include, we could find very little amount of work that was already done, systematic reviews and meta-analysis done on oncology and comparing it with artificial intelligence. And even the usage of artificial intelligence was more restricted to using machine learning, whereas deep learning systems and convolutional neural networks, that are the deep learning methods, are being used in a very limited sense. So we believe that first of all, we need to improve the current technology that is available. So networks should be better designed and should now involve deep learning systems so that high resolution images could be obtained, and we could better train these systems as they require a lot of amount of input. For now, machine learning algorithms could be trained on standardized local data sets, but most of the data sets that are available are from high income countries, whereas most of the mortality lies in the low income countries. For the future, we believe that improving and utilizing machine learning and deep learning system for clinical diagnosis could be very beneficial, especially where there is absence of neuroradiologists.
Thank you so much, Dr. Chatterjee. Sorry, we don't have time for the discussion because we have another meeting now on TUGS Fellowship. So thank you so much, everyone, to joining our TUGS Scientific Sundays this month. Hope to see you soon in March, and thank you for joining.
Thank you very
Good
much.
evening.
Good day.